Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. We're so happy you're joining us for our discussion today on MIPS and the social determinants of health. This discussion is part of our broader series on the practice of medicine, which looks at policy issues and how they affect medical practice. The series is sponsored by the Physicians Foundation, and you'll hear from the president of the foundation in a moment. The topic we're discussing today brings together two threads that we've reported on a great deal in health affairs, and if you're with us today, I'm sure you're familiar with both of them. One is changing payment policy within the Medicare program. When the Sustainable Growth Rate, or SGR, was repealed, it was replaced with a new set of approaches designed to encourage high-value care and not simply to penalize all physicians for growth in volume provided by all physicians. MIPS is a part of a complex system that increases those incentives and creates those incentives within Medicare. Similarly, the healthcare sector is paying growing attention to the social determinants of health. There's growing understanding that clinical practice is only a portion of people's health, and that addressing social needs is critical to achieving good population health. These two topics come together in the physician's office as well as other places, where physicians are expected to both meet performance standards with respect to Medicare and address social determinants that may not have been their focus not very many years ago. It's the complex interplay of these two that affects what it really looks like to provide care and to receive care, and that's what we're going to discuss today. In typical health affairs style, what we always like to do is to bring together scholarship and practice. And so today you're going to hear from three authors of papers who will present research that they've conducted on this topic and that we've published. You'll hear from CMS about how implementation of MIPS is going, and you'll hear from three practitioners who are looking at how to incorporate social determinants into clinical practice. We think together they'll provide you with an exceptional variety of perspectives on this complex and important issue. But before we turn to the presentations, I'm happy to introduce to you Gary Price, board member and president of the Physicians Foundation. Dr. Price is a board-certified plastic surgeon. He serves as an attending surgeon and clinical assistant professor of surgery at Yale New Haven Hospital. He's a past president of the Connecticut State Medical Society. We've enjoyed working with you in your role with the Physicians Foundation. Gary, I'll turn it over to you.
Thank you very much, Alan. Over the past decade, state and federal governments, health insurance companies, healthcare delivery systems, and physicians have struggled over who should bear the financial risk when patients get sick. Increasingly, this risk is being shifted to physicians, holding them responsible for our patients' health through quality measures tied to financial rewards and penalties. Yet, as more and more data are showing, the inescapable conclusion is that the U.S. will not be able to improve the health of its population, nor constrain its spiraling healthcare spending, without addressing the high cost of caring for patients at the bottom of the economic ladder. Today, social and environmental factors such as access to healthy food, safe housing, and other social determinants of health drive up to 70% of health outcomes. In the Physicians Foundation's 2018 survey of more than 8,500 physicians, almost 90% reported patients with serious health problems linked to poverty or other social conditions. Over the last 7 months, COVID-19 has caused enormous suffering for Americans while shaking the foundations of our healthcare delivery system. In the midst of all this, the Physicians Foundation sees a path forward to a better healthcare system, one that recognizes the realities of patients' lives and rewards and invests in health. We cannot be afraid to seize this opportunity to improve health outcomes. The Physicians Foundation's mission is to support and empower all physicians to provide high-quality care and take a leadership role in shaping the future of healthcare via research, education, and innovative grant-making. For the last 10 years, the Foundation has been funding research and interventions on social determinants of health. In the wake of COVID, any significant conversation about reforming health and health care must go beyond clinical care to include addressing social determinants of health if it is to be meaningful to practicing physicians, relevant to population health, and reasonably expected to reduce costs and improve outcomes. Before I turn the podium back to Alan, I want to say a very sincere thank you to Health Affairs. The Physicians Foundation is extremely proud to sponsor today's event. We see it as the first day of the Foundation's next 10 years of focus on social determinants of health. Thank you so much for joining us today.
Thank you, Dr. Price. I really appreciate those comments. And let me tell the audience how we're going to proceed from here. We're going to have a number of presentations on a few separate panels, but we're going to reserve question and answer to the end so that as many of our panelists can participate in the discussion as possible. Below the screen where you're watching us, you will see a place where you can ask questions. Those will come to me. I encourage you to submit them at any time. In fact, the earlier the better. It gives me more time to review them and prepare for the Q&A period. But please, and I'll make a reminder as we are a little further in the agenda, but please don't wait to ask your questions until the end. As soon as you think of them, please go ahead and type them in. So first, we're going to hear from our three authors who've had papers in Health Affairs as part of the Practice of Medicine series, all looking at different aspects and dimensions of MIPS and social determinants. You're going to hear from Alex Sandhu, instructor of medicine at Stanford, a cardiologist whose research is in heart failure and health economics. Kenton Johnston, assistant professor of health management and policy in the College of Public Health and Social Justice at St. Louis University. And Nate Apathy, a postdoctoral fellow in health services research at the Perelman School of Medicine and an associate fellow at the Leonard Davis Institute of Health Economics at the University of Pennsylvania. I'll turn it over first to you, Alex.
Thank you, and thank you for the invitation to share our research with you. Not sure if I have control of the slides or if I'm supposed to share the slides on my end.
Announce when you want to move them forward. We'll move them for you.
Okay, we can go forward. Next slide. So here are disclosures. I do health policy consulting for Acumen. This work was performed under CMS funding for measure development. Views expressed don't necessarily reflect those of CMS or HHS. Next slide. So MIPS is a clinician value-based payment model that adjusts payment based on 4 categories: quality, promoting interoperability, improvement activities, and cost. In the 2019 performance period, MIPS cost category is based on 2 population-based cost measures and 8 episode-based cost measures. The 2 population-based cost measures, total per capita costs and Medicare spending per beneficiary, were originally in the value-based payment modifier program. The 8 episode-based cost measures were recently developed. Next slide. And here is a list of the, next slide. Here's a list of the 8 episode-based cost measures. The measures focus on costs related to a specific high-priority clinical scenario, a hospitalization, or a procedure, with chronic disease management measures that are now currently under development. The really important concept about these measures is that they only focus on the costs being evaluated related to the episode. So for example, for a knee replacement measure, costs related to a car accident that occurs 2 weeks after the surgery or a routine eye appointment wouldn't be considered and evaluated in the measure because they're unrelated to the care being delivered by the orthopedic surgeon. Each of these measures were developed with detailed input from a committee of clinical experts in the measure area. Next slide. Here's a schema of the measure for PCI, where you see the checkered triangle is kind of where the PCI occurs. And then the yellow triangles are services that are included in the cost calculation, with the white triangles being services that weren't included. And what you see is before the PCI, there's no services that are included in the calculation. After the PCI, there might be certain services performed by the interventional cardiologist who's attributed the measure that are included, such as a follow-up office visit or an electrocardiogram. And then there's services provided by other clinicians. And some of those will be included because they're related to the PCI, potentially a stress test or an echocardiogram performed by another cardiologist, while others might not, such as an eye appointment that's kind of unrelated to the PCI. Next slide. The measures adjust for HCC disease indicators, reason for Medicare eligibility, long-term care residence, MSDRG. Clinical experts also selected additional risk variables specific to each measure and added exclusions for certain high-cost outlier populations. For some measures, there's also risk model stratification based on key characteristics that we term subgrouping. Besides those variables that might correlate with social risk factors such as disability or long-term care residence, there's no additional adjustment for social risk factors in the base risk model. Next slide. In this analysis, we set out to understand if adding social risk factors to the risk model changed clinician performance on these 8 episode-based cost measures. To study this, we added the following variables: sex, race, dual Medicare Medicaid eligibility status, and AHRQ SES index, which is a community-based score of social risk based on census data related to income, unemployment, housing, and other factors. We calculated the score at the level of the block group, so about 600 to 3,000 people. The analysis was conducted using all Medicare fee-for-service patients in 2018. Next slide. Here you see the number of dual eligible beneficiaries for each of the 8 measures. And then in the 2 columns on the far right, you see cost ratios for duals versus non-duals across the 8 measures, with and without base risk adjustment. What you see is for several of these measures, costs are fairly similar without even risk adjustment. After risk adjustment with the base model, cost is within 3% for 5 of 8 measures and within 6% for all 8 measures. Next slide. Next, we added sex, race, dual eligible status, and AHRQ SES index and recalculated measure scores for each clinician. Here's a distribution of the change in measure performance compared with the base model. Very few clinicians have substantial movement beyond 10 percentile points in their performance. For 4 of the 8 measures, less than 1% of clinicians move more than 10 percentile points up or down. For the other 4 measures, the percentage of clinicians that move more than 10 percentile points range from 1.7 to 3.4%, with the measure with the most movement being knee arthroplasty. Next slide. And here's a box and whispers plot where we stratified clinicians by their proportion of dual eligible patients, with quartile 1 having the fewest dual eligible patients and 4 having the most. Y-axis is change in measured performance percentile with social risk factor adjustment, with movement up being worse performance and movement down being improved performance. Boxes are the interquartile ranges. What you see is that the absolute movement is quite small across quartiles. For most measures with movement, the quartile with the highest proportion of dual eligible patients have improvement in their score with social risk factor adjustment, which is what you'd expect. There are exceptions, however, in colonoscopy and PCI where you actually see the opposite phenomenon. Next slide. The main takeaways are that costs were quite similar for a number of measures between dual and non-dual eligible beneficiaries even before risk adjustment, and social risk factor adjustment didn't substantially impact clinician measure performance. There's a few reasons why our results might differ from prior studies and prior ASPE results. First, these cost measures are narrower, focusing on costs related to the specific clinician-patient relationship being evaluated. Some of the increase in costs previously observed among patients with significant social risk might be mediated by a range of healthcare risks and complications that are often unrelated to the condition under evaluation. Second, there might be patient selection, especially amongst the elective procedures. And finally, these measures use more specific risk models designed for each measure with both additional risk factors and exclusions that might partially adjust for these differences. A couple of important limitations. First, we didn't calculate overall impact on MIPS score only for the individual measures, although we suspect the impact on composite score would be small given our findings. Second, we didn't have individual level data on multiple social risk factors and thereby use a community level risk marker, which might miss heterogeneity within a geographic area. I think this really emphasizes the need for more work in capturing individual level socioeconomic characteristics to better understand the interaction between social risk and healthcare costs and quality. Finally, this work addresses how social risk factor adjustment would impact clinician performance. While important, in addition to that, there are still important questions as to what drives observed cost differences. This includes a better understanding of how much observed cost differences are related to within clinician differences for a clinician when they treat a high versus low risk patient, versus differences between clinicians. I think this is going to be a really important area for future research. Thank you very much.
Thank you so much for getting us started. We'll turn now to Kenton Johnston. Kenton?
Hi. Thanks for attending my presentation. If we could go to the next slide, please, I'd appreciate that. Okay, so this presentation is based on a paper that I published with some colleagues who I'd like to acknowledge: Jason Hockenberry, Rishi Wadhera, and Karen Joint-Maddox. We published this in the September issue of Health Affairs. And so the focus here is looking at clinicians with different social risk caseloads to see what impact having a high versus a low social risk caseload has on merit-based incentive payment system scores. And as you can see from the title, the takeaway is that clinicians who serve disproportionately high caseloads of socially at-risk patients receive lower MIPS performance scores. Could you move it to the next slide, please? Thanks. Okay, so for those of you who don't know a lot about the MIPS, 2019 was the first performance year. The MIPS was originally passed into law, enacted in 2015 under the Medicare Access and CHIP Reauthorization Act. And 2017 was the first year that performance data was actually collected on clinicians, and then that was used to score them in 2019 and give them payment adjustments, so penalties or bonuses. Prior research of past Medicare value-based payment programs, in particular, I'm thinking here of the Hospital Readmissions Reduction Program and the precursor to MIPS, the Physician Value-Based Payment Modifier Program, have found that those programs disproportionately penalize the safety net. In other words, clinicians who served more poor or otherwise socially at-risk patients tended to perform worse in those programs. In recognition of this, CMS actually developed something called the Complex Patient Bonus, which they're going to add to MIPS in the year 2021, so next year. And what this bonus does is it adds points to clinicians who treat disproportionately high caseloads of patients who are socially and medically at risk. All right, could you move to the next slide? Thank you. So I'm not going to get into my methods today. You can read those in the paper. This slide shows you the basic takeaway from our study. We looked at about 650,000 MIPS participating clinicians, and we compared those with high social risk caseloads, so in the top quintile for proportion of Medicare beneficiaries who are also duly enrolled in Medicare, or Medicaid, I should say, versus the bottom quintile, those with low social risks. Caseloads. And as you can see, those with a high risk caseloads performed about 10 percentage points worse. They got a final MIPS score of 63 versus 73 for those with low social risk caseloads. And if the complex patient bonus had existed in 2019, we estimate that it would have had a very limited effect. It would have increased the final score for those with high social risk caseloads by 3 points to 66. Then if you look in the next set of bars, which is the percent of clinicians receiving negative payment adjustments or payment penalties, you can see in orange that those with high social risk caseloads, 11% of them receive penalties. That's 5 percentage points more, almost double the rate of penalty among those with low social risk caseloads. And you can also see that the complex patient bonus would not have had an impact on the proportion of those receiving penalties. And the main reason for that is that in order to be eligible for the complex patient bonus, clinicians needed to report data to CMS. And in 2019, those who received payment penalties did not report any data to CMS. When it comes to positive payment adjustments, the threshold was very low in 2019, so most clinicians received some kind of positive payment adjustment, although that was slightly lower for those with high social risk caseloads. And then another proportion of clinicians received exceptional performance bonus payments. So if you received a score of at least 70, you received an exceptional bonus payment. And you can see the percentage of those with high social risk caseloads was much lower who received that. It was 13 percentage points lower, and the complex patient bonus would have had a pretty limited effect on that. All right, let's move to the next slide. So in this slide, what we're looking at are multivariable regression results. So again, the independent variable is high versus low social risk caseloads. But here we're adjusting for all kinds of different clinician characteristics, practice characteristics, patient caseload characteristics, and local area characteristics in the clinician's practice area. And so you can see that the adjusted results show those with high social risk caseloads received 13.4 point lower final performance scores. This is on a range from 0 to 100. And with the complex patient bonus, that would have been 11.6 point lower. And as the results show, the likelihood of receiving a negative payment adjustment with an odds ratio of 1.99 means that those with a high social risk caseload had a 99% higher likelihood of receiving a payment penalty. And that was unchanged with the complex patient bonus. And then the likelihood of receiving a positive payment adjustment or an exceptional performance bonus payment was about 50% lower for those with a high social risk caseload. Again, very little change with the complex patient bonus. So let's move to the next slide. So what our basic takeaway from this study is that having a high social risk caseload as a clinician is associated with poor MIPS performance scores and lower reimbursement. And we also conclude that the complex patient bonus would actually not have been that helpful to these clinicians in 2019. It would not have increased their scores by a meaningful enough amount to move many from the penalty status or into the bonus status. In terms of the reasons why, so this is debatable. One thing we looked at is we looked at some of the individual performance measures, and we found that clinicians with high social risk caseloads performed worse on a lot of the technology-dependent measures. So, for example, having clinical reporting registries. And this suggests that one potential reason is these are lower resourced practices who may lack some technological infrastructure to report these measures. Another potential reason for this that's been noted in prior studies is inadequate risk adjustment. So some of the measures included in the quality scores were outcome measures, which prior research has shown are associated with social risk factors. And then finally, the third reason is actual lower quality of care. It's certainly plausible that Medicare beneficiaries who live in poor areas have less access to high quality clinicians, and perhaps to a certain extent, these scores are reflecting the quality of care that they're actually receiving. All right, next slide. That's it for my presentation. I want to turn it back over to Alan. If you have any questions, feel free to ask or reach out to me by email. Thanks a lot.
Thank you so much for that presentation. I'll turn it now to Nate Apathy. Nate?
Hey, thanks. Thank you to everyone for attending, and thanks to Health Affairs for the invitation and opportunity to participate. I'll be presenting some joint work. Actually, we can go back. There you go. Some joint work with Jordan Everson, where we look at the composition of these MIPS final scores and find kind of high rates of category skipping, especially of advancing care information component, which Kenton kind of alluded to in his discussion. Our work doesn't explicitly tie MIPS participation or partial participation to social determinants or patient social risk like the two previous papers we just saw, but we've done a little bit of extended work to look into how skipping ACI in particular may be emblematic of a digital divide between providers who treat patients with greater social needs and providers who have less socially vulnerable patient populations. This will relate directly to kind of what Kenton just discussed. I'm going to go to the next slide. So our goal really in this project was to just unpack the composition of MIPS final scores. The top line numbers that we get from CMS don't tell us a whole lot about how providers varied in their choices of what to report within MIPS. Since providers could achieve the same overall score in different ways, we wanted to understand how exactly providers were attesting to MIPS in the first year in 2017, or when they were graded in 2017. You can go to the next slide. We ended up finding a substantial amount of category level scores of 0. And so we looked further into this phenomenon of kind of category skipping, as we ended up terming it, And the major takeaway from our paper is that nearly half of all clinicians reporting to MIPS skipped at least one category for reporting. And we can advance the slide. And when you dig into individual categories, the most commonly skipped category was ACI, which is the sort of version of the Meaningful Use or EHR incentive program, with over a third of clinicians skipping that component. So the original goal, which is kind of to bring together these three quality programs, ended up in this first transition year, sort of, and this was part of the intent, right, to relax those programs for clinicians who needed it or found MIPS to be too administratively burdensome. So in part, due to this skipping, the final scores in the first year of MIPS, like these aggregated scores, tell us more about participation in each category and don't tell us a whole lot about clinician performance within each category. So we ended up calculating that about 86% of the variation in final MIPS scores was attributable to just participation rather than performance within categories. And that's the case because when providers didn't skip a category, there was very little variation in performance. And so we'll look at ACI here as an example. You can advance. This is a slightly different view of ACI scores from Exhibit 3 from our paper, but you can see that 4 out of 5 clinicians either did perfectly or got a 0. There were relatively few providers that scored anywhere between 0 and full points on ACI. But just looking at that top bar of providers who reported 0 on ACI, you can see that they're not a homogeneous group. Some ended up actually getting positive and exceptional payment bonuses despite their 0 on ACI, which means that they scored well on quality and improvement activities, which were the other 2 components in the first year. Others received negative adjustments, and in fact, what this plot is telling us is that all clinicians who received negative adjustments got 0s on ACI, which is kind of what Kenton alluded to earlier. And this implies that the ACI goals were either too difficult to attain or too administratively complex to report for these providers. But to some degree, we can intuit that some proportion of these clinicians in the red are systematically disadvantaged when it comes to MIPS reporting goals, while those that are in green and blue who got payment bonuses could have technological disadvantages or could be sort of shirking the ACI reporting requirements or have difficulty with those reporting requirements because they did well in other categories. And so these divisions kind of highlight a digital divide at the clinician level that correlates with the divide in the social risk of the patient population that these different providers treat. So if you can advance one, we kind of borrowed a measure of social risk. You can advance the slide. We borrowed this measure of social risk, right, the proportion of clinicians, patients that were dual eligible, and found that compared to clinicians who got bonuses, these sort of negative adjustment providers tended to treat a greater proportion of higher risk patients, right? This is sort of what we just saw with Kenton's work as well. So we can go to the next slide. And so what do these findings really mean for how MIPS intersects with social risks and social determinants of health? Our major finding of this high rates of skipping kind of leads us to conclude that MIPS was unlikely to drive incremental improvement in its first year. You kind of had these well-resourced high performers for whom successful attestation was relatively easy, and it's unlikely that those practices are making a ton of marginal progress in that year of the program, which is part of the point of a transition year, right? But more importantly, the clinicians that got negative payment adjustments both all scored 0 on ACI and tended to treat higher risk populations, which means that those providers that were punished by MIPS represent the sort of have-nots in terms of technology and the high needs providers in terms of social risk management. You could advance. And we've seen a similar digital divide among critical access hospitals, and we know that the use of advanced technology like social risk prediction algorithms can effectively target support services, but it's not clear that the first year did anything to first year of MIPS at least did anything to help close this gap, and may have widened it or introduced additional barriers for those who saw reimbursement reductions. So go ahead and advance. What does this mean for going forward? We can focus on kind of customizing measures according to baseline performance levels, doing further risk adjustment, like Dr. Sandhu presented, adding measures that explicitly incentivize the use of technology to support the assessment of social determinants and social risk, and also ensuring that providers who need additional support to sort of get up to baseline levels do get that support, as opposed to simply avoiding the penalties. So that's all I have for today, and thanks everybody, and look forward to the discussion.
Great, thank you so much. So as we move forward in our agenda, I just want to note we're still taking questions. We are recording this event. It will be posted on the event page. The slides are available there as well. And as I noted at the outset, if you missed, we will do one consolidated question and answer after we're done with the presentations. Next, I'm really pleased that we have joining us Michelle Schreiber. She is the Director of the Quality Measurement and Value-Based Incentives Group at CMS. She's a general internal medicine physician who was the Senior Vice President and Chief Quality Officer of the Henry Ford Health System in Detroit. She's also had senior leadership roles at the Detroit Medical Center and with Trinity Health System. It's a great background to bring to this really important role at CMS. And I know it may seem a little odd to do it after these presentations, but I think it's important to present some of the new findings that we have before we go into this overview of where we are and where we're going on MIPS. So Dr. Schreiber, the floor is yours.
So thank you very much. Let me do a sound check. You can hear me? Yes?
We can.
Okay, wonderful. Thank you. Thank you so much for the invitation to be here, really. And social determinants, as you pointed out, my long career in Detroit is very important to me. My primary care practice was in the city of Detroit for over 20 years. Next slide, please. Next slide. Thanks. Many of the prior presenters have actually covered a lot of these points, so I'm going to go relatively quickly in the beginning. The inception of MIPS was in 2017, and it was meant really to promote value for clinicians. So there were other value programs, there were hospital programs, nursing home programs, but this is the one that was aimed at physicians, to bring physicians into value-based payment, where clinicians had to consider their outcomes for quality and for cost and how they were doing in promoting interoperability. And as you know, it combined prior systems, took into account answering for the SGR, and combined it into what is now the MIPS program. Next slide, please. The MIPS Next slide. Thanks. The MIPS program has two tracks. The traditional track is what we call MIPS, the Merit-Based Incentive Payment Program, and there is also the track for the advanced payment models. As it stands now, there are approximately 1.6 million clinicians in the United States, and of those, roughly speaking, 900,000 participate in the MIPS program in one of these tracks. What we're very excited about is that there has been an increased number of physicians who are able to participate in APMs. That has moved from 99,000 in the first year to about 183,000. So we are seeing more clinicians who are moving towards APMs. Next slide, please. Next slide, please. Thanks. As has been pointed out, there are four categories in MIPS. There's quality, there's cost, there's improvement activities, and there's promoting interoperability. And you can see the percentage distribution. Now, this will shift over time. By statute, cost has to become 30% of the program, I think by 2022, so that this will be moving forward. And when that happens, quality will also go down to 30%. So 30% quality, 30% cost, improvement activities at 15%, and then promoting interoperability. Thank you. And so clinicians do, in theory, have to participate in all of these, but as we have seen from prior presenters, you can skip one of these categories and your score will be reweighted accordingly. On the next slide, please. We have a number of MIPS eligible clinicians. It's not just physicians. We've tried to be as inclusive as possible and have added clinicians every year so that you can see there's actually a wide range of clinicians that are available. On the next slide, sorry, because there's a little disconnect between where I see the slides moving forward and perhaps where you are seeing them. You can see that the participation rates have really been very high. It was interesting to see the prior presenters' data when you looked according to duals. We've also looked according to large practices and small practices. The largest percentage of clinicians actually report as large, and in many cases, very large practices. In other words, a single tax ID number, a TIN number. We have obviously many clinicians who also report as small individual practices, but we have fewer physicians who participate as smaller practices than we do for others. And we see the change in scores actually correlated with the size of the group that is reporting, in addition to some of the other factors that you have spoken of. Next slide. In 2017 versus 2018, you can see the differences in individual and group participation in terms of the total number of clinicians receiving a MIPS payment, the percentage who have been above the performance threshold. So in 2018, we have even more clinicians who are above the performance threshold. And we had a lower number of clinicians who were below the performance threshold, hopefully because people were starting to understand what it took to participate in the MIPS program. These numbers will change over time, especially there will be an impact of the COVID pandemic because we made reporting, at least in 2019, optional, and we're starting to see the results of that now as to how many clinicians chose not to report. It's actually not as large a number as many people would think, but it may affect how many clinicians actually get a bonus versus not. So we will see what the numbers show. Next slide. We looked at performance indicators. I think one more. This is the MIPS APM participation. There we go. And we'll talk about the performance indicators. So as I said, in a total group of about 1.6 million clinicians in the country, there are about there's close to 700,000 non-eligible clinicians. Many of these are clinicians who are right out of training, or they don't have a lot of Medicare patients to qualify. So if you think pediatricians, obstetricians, for example, don't necessarily qualify because you need a certain number of Medicare patients. We have over 95%, and actually in the last year, over 98% of clinicians who are participating. But you can see the numbers here according to group size. It is certainly skewed to groups that are larger than 100 clinicians. And again, this goes by tax ID number. When we first started, the performance threshold, as you recall, was just 3 points. And quite honestly, that was set specifically to attract physicians into the program and to give them the opportunity for a lot of flexibility and choice and really just to enter the program. We have finalized for 2019 that the performance threshold will be at 60 points. So as this continues to grow we'll probably start seeing different distributions of bonuses and non. There is an exceptional performance threshold of 85. If you'll recall, Congress allocated $500 million as a special pool of money to pay for those clinicians who are at exceptional performance levels, and that score is at approximately 85. The average bonus, though, is about 1.5%. For those who are in the exceptional performance, it's about 1.79%. So the bonuses have not been huge. And I recognize that there had been the promise of up to 9% bonuses and frankly up to 9% negative penalties as well. This so far has not transpired, but there is progress over time such that we anticipate in the coming years we will start getting to distributions, especially as the performance thresholds change, where we will see more money being paid out in bonuses. If you recall, this is a net neutral program. And so bonuses paid come from penalties that other clinicians have. So it's a net neutral. Next, please. There have been a number of successes in MIPS that we're really very excited about. The high participation rate in particular, the increased understanding of the program, improved clinician satisfaction scores. So we do survey clinicians about their feelings about MIPS, and we've had higher clinician satisfaction scores, and there were more, flexible choices for a long time. As a primary care physician, I'm excited that there's been a primary care focus in this, but that's also one of the criticisms, which I'll get to in a moment. But we are excited that more clinicians are really engaging in quality and cost evaluation and moving towards value-based payment. The ongoing challenges, however, as you can see on the next slide, is that there have been many concerns that this is too confusing. There are too many choices. In the quality category alone, there are well over 200 quality measures that can be chosen, although we're narrowing that choice down over time through our Meaningful Measures initiative and our Patients Over Paperwork, where we're removing low bar measures or measures that are topped off. It is burdensome for some clinicians to report, but for many clinicians, it hasn't been, and usually those are clinicians within large systems that are capable of doing reporting. Many specialists have felt that this is less relevant to them because it has been primary care focused, especially in many of the measures. Many specialties, especially those who are in the large tax ID numbers where it's the primary care measures that are being reported as opposed to specialty ones, have felt that it's less relevant, and we're trying to address that in MIPS going forward. We spoke already about insufficient financial incentives, but again, that hopefully will change over time as the performance threshold change, and that it's difficult for smaller and rural practices to perform well, and in part, that's where the complex bonuses came in also. Clinicians have some concern about the ability for us to establish benchmarks and particularly attribution. This has come up especially in the cost measures, is that how are you attributing that cost to me and my practice as to what I really did? We're trying to answer many of these concerns with our next iteration of MIPS on the next slide, which is moving to MIPS value-based programs, MVPs. CMS has proposed to create a new participation framework called the MIPS Value Pathways, and they will begin in the 2022 performance year. So this new framework is really meant to be a measure set that unites and connects measures across the activity of cost, quality, promoting interoperability, and improvement activities. They incorporate a set of foundational administrative claims-based quality measures, such as population health measures or public health measures, and they also streamline MIPS reporting. They're going to limit the number of measures that are needed, and they will be developed in collaboration with specialty societies. So on the next slide, let me give you an example of what I'm talking about. This is a potential or theoretical surgical MIPS value pathway. So on the what is my left-hand side, you can see 4 really disconnected quality, promoting interoperability, improvement activity, and cost measures that are currently reported. Over time, for example, and let's just pick on something like general surgery, what might be important outcomes or quality measures for general surgery? Well, it might be return to the OR unexpectedly, for example, or it might be mortality, or it might be other complications. Tying those quality measures that are important to a surgeon to improvement activities that are specifically linked to those quality measures, tied to costs. So you can imagine, for example, in internal medicine, if you had a diabetes MVP, the episode-based cost of diabetes, all right? And then tying that to promoting interoperability, which will largely be a foundational report for promoting interoperability. But there can also be things such as, have you engaged your patients in patient portals and you're using that for their care? So in other words, linking an important outcome such as improving diabetes care, improving surgical care, tying them together in a cohesive set that is developed in collaboration with the specialty society so they're meaningful and relevant for individual practices, reducing the burden of reporting and making these more cohesive is where CMS is moving towards the future. I do want to say just a word about equity. We are working to understand where we can best place equity. We don't have, as you all know, good quality measures around social determinants of health. We've always used dual eligibility as, kind of a proxy, but we are certainly looking for how we can best incorporate concerns of equity into the MIPS program. And we're always soliciting feedback and look forward to partnering with the external community. So thank you again for the opportunity to present today.
Thank you so much for joining us today and giving us that thorough update on where we are and where you're going. We're now going to hear from three folks who are working with these issues out in the field. I'll name them all now and then introduce them in turn as it's their time to speak. We'll be hearing from Karen Smith, a family physician in private solo practice in the rural community of Rayford, North Carolina. She has worked with a quality improvement organization on successful implementation of MIPS, serves on a number of advisory groups for the federal government, and has been recognized as the North Carolina Family Physician of the Year in 2016 and the American Academy of Family Physician of the Year in 2017. That's quite an honor. We're so happy to have you with us. You'll then hear from Rocco Perla, co-founder of the Health Initiative, which is a campaign to catalyze national efforts to move toward greater investments in health. Rocco was the president of Health Leads, and before that, part of the leadership team that established CMMI, the Center for Medicare and Medicaid Innovation. He's an assistant professor at the UMass Medical School. And Himal Kanzaria is the medical director of the Department of Care Coordination at the Zuckerberg San Francisco General Hospital, also an associate professor of emergency medicine at UC San Francisco. So three different perspectives on what it means to attend to and work on the social determinants of health. I'll turn it over first to Dr. Smith.
Thank you. The MIPS program really was a lifesaver for our practice, and our adventure started with recognizing we needed to have three factors identified and addressed. One, we had to have physician participation, and I'm solo, and that meant I needed to participate in the program if I was going to reap the benefits. But our patients also needed to be engaged. They needed to be aware of what it was that we were doing for the sake of the community, for the sake of their individual care. And then finally, the structure. We needed to have some assistance with getting the structure necessary that will allow us to be successful with the MIPS program. That's a pretty tall order. And I could tell you my inspiration actually started, and the very day was October 23rd, 2014, when Sylvia Burwell presented to the American Academy of Family Physicians a proposed $840 million that would be utilized to get practices ready, practices like my own. I can also tell you that my inspiration started a little bit before that, because you see, Dr. Kent Brantley came on stage and spoke of his near-death episode with Ebola. But to hear what the United States of America did and how we assisted with the global efforts via the World Health Organization, and that family physician appeared on stage, and Sylvia Burwell appeared on stage, and she said, this is what we're going to do to help transform healthcare in America. And so we all know the history. We certainly launched the TCPIs, the Transforming Clinical Practice Initiatives. We then had our Practice Transformation Network, and we actually were in two of them. And then we moved over into the ACO mode. We received assistance from the AIMS funding, but I had also participated with the Minor Population Health Program. And I had also had the opportunity of being a meaningful use vanguard with the Office of the National Coordinator. So our practice was already pretty rich with having the technology structure necessary. And we then started that adventure in terms of MIPS and what we could do. But we did one other thing. We also participated with the Quality Physician Payment Program with the Clinician Champions, meaning we went up to Baltimore and we learned all the different aspects of how can we be successful with MIPS, but better yet, how can we share that information with our peers our colleagues across the country? How can we present that information to them? And so the MIPS program, yes, it was quite complex. And we did move through that. We did finally land into an ACO that really made a difference. And that ACO recognized that social determinants of health was standing in the way of allowing us to get beyond checking boxes, but actually providing quality care to the patients who are in our communities. We are independent, we're rural, we're in multiple different locations. But this particular ACO recognized that we needed to pay attention to the structure of healthcare in America, beyond that infrastructure that exists in my office, that we needed to pay attention to the barriers that were created by structural racism, by the barriers of poverty and lack of transportation. And by the way, it's not necessarily that the physician is poor in quality, but that the physician is not able to provide those high quality services, which is deserving of all people in our country. Just as Kent Brantley received what our country could deliver, every person in our country, through the benefits of the Affordable Care Act, should be able to receive that same level high quality care. So our ACO does pay attention. We are currently working on a hypertension initiative. We are using technology and data to recognize those patients who do not have good control of hypertension, who do not have good control of diabetes. But the question becomes why? And to dig into that and to look at those structures that are preventing them from getting and achieving good quality care. So it has been a long road, and we are concerned. It's interesting. Yes, we have the complex patient bonus, but maybe we need a complex society bonus. Maybe that is what's going to make the difference to raise us up from being not the best in terms of our communities to actually being able to provide high quality service to every person who lives in this country.
Thank you so much for kicking us off with that perspective and experience. Now I'll turn it over to Rocco. Rocco.
Thanks, Alan, and thanks to Health Affairs and the Physicians Foundation for this conversation. I'm going to situate my remarks along a brief timeline. So in 2011, I joined CMS as part of the leadership team at CMMI that helped develop some of the early payment models and laid the foundation for MACRA, MIPS, and the value-based payment goals, recognizing clearly that it just isn't possible to have a just, equitable, person-centered, cost-effective healthcare system when disease burden equals revenue. And yet, almost immediately at CMS, I saw a disconnect between the policy choices we were making and the realities of beneficiaries' lives. For example, through MIPS, we measured the percent of diabetics with a hemoglobin A1C that was greater than 9%, but we never measured the percent of diabetics that were forced to choose between buying food or buying medicine. The realities of people's lives, or what we might call the drivers of health, were not part of how we saw our job, because the main question we were relentlessly focused on was how do we deliver high-quality clinical care at lower cost? That is a really important question, but if we're honest with ourselves, we know that's not going to deliver health. That was true before COVID, and it is certainly true now. Fast forward to 2016, I just left CMS and joined Rebecca Oney at Health Leads, which sought to screen every patient for unmet resource needs, navigate them to those resources, confirm the resource need was met, all as a standard part of care. We weren't using dual eligibles or Medicaid status as a proxy for risk. We just asked people, are you worried about running out of food at the end of the month, about paying your bills? In the United States, everyone asks about and argues about healthcare all the time, especially right now. But what do people think about health? No one can answer that question for us. So we launched a new initiative and hired a polling firm to ask voters across the country, what do you need to be healthy? In Charlotte, North Carolina, we asked African-American Democratic women and white Republican women, if you had $100, how would you spend it to buy health in your community? And there's the results. It turns out they agree. First, they choose to invest most of their money outside of hospitals and the health system. And second, they agree on what drives their health, spending about 19% on affordable housing and 25% on access to healthy food. And they're not alone. As you can see on the next slide, from Texas to Washington, North Carolina to Ohio, black, brown, or white, rich or poor, Republican or Democrat, people were super clear on what they need to be healthy: a safe home, healthy food, and a decent job. And what's so interesting is when we posed the same question of physicians in North Carolina, the results were nearly identical, except these physicians would spend even less on traditional healthcare and more on the drivers of health. That's on the next slide. What's really important to note here is that addressing the realities of patients' lives isn't just the right thing to do, it's the economic thing to do. 24% of people with commercial insurance, meaning they have jobs, screen positive for an unmet social need. And that means higher medical costs, anywhere up to about $4,400 more for a diabetic who's food insecure, all of which impacts physician burnout. In a value-based payment environment, this represents financial risk to everybody: patients, payers, physicians. How does our notion of risk change when nearly 60 million Americans have filed unemployment in the last 6 months? How does that play out for physicians as we expect them to assume more risk? Now, federal stakeholders say that they're primed to address these drivers of health as a CMMI pilot, specifically the Accountable Health Communities model that recently announced that 33% of the beneficiaries screen positive for an unmet need. And through a 2021 rule change to the medical loss ratio, where CMS allowed non-medical services like meal delivery to count as healthcare expenditures as a way to deliver higher quality, lower cost care. But that was only for Medicare Advantage chronically ill members. That's all great, but the drivers of health are nearly absent when it comes to the regulatory and financial realities of MIPS. I think we just heard Michelle say that. Of the 276 MIPS measures, there isn't one that addresses food or housing instability specifically. And so you can just feel this tension here. We know, Americans know, that health is what's most important, yet it's more of a side project. Why? Why is that the case? I asked that question to Tom Nolan, the architect of the triple aim, the idea that we can improve care, improve health, and lower costs all at the same time. And when Tom and I spoke, I asked him, where did the triple aim actually come from? Why are there 3 aims? Why not 2 aims or 4 aims? And Tom said this: the triple aim was essentially 1 aim, health, but we all got co-opted into focusing on care and cost because that's what the healthcare system knew. It's the biggest regret of my life. 4 months after we talked, Tom died. And I think he knew he was dying when we spoke and wanted to tell someone, anyone, that we kind of got it wrong. We now have the opportunity to align what Americans say and know they need to be healthy with our health policy agenda. Value has created the chance to have the real conversation about health. And that was a conversation we couldn't have in a fee-for-service world. And so how do we do that? I don't think it has to be complicated. In 2021, the Quality Payment Program could lead the way by incentivizing physicians practicing in MIPS and APMs to use existing CMS screening tools to understand their patients' unmet needs. They could then use that data and construct the first drivers of health measure set in the program's history. That should be pretty straightforward. And if we want to be even more ambitious, HHS could establish a national payment goal that focuses on the percentage of our $4 trillion healthcare spend that is tied not just to value, but to health. We could call it health-based purchasing. The country has never needed our healthcare dollars to buy health more than it does now, and MIPS could be the first step to do that. Thank you.
Thank you so much for those comments. And last but certainly not least, I'll turn it over to Hemal Kanzaria. Hemal, the floor is yours.
Thanks so much, everyone, and thank you for having me. I'm going to speak as a frontline emergency physician at San Francisco General, which is a large public health organization in San Francisco County, as well as a healthcare administrator overseeing programs focused on helping meet patients' health-related social needs and integrating medical and social care. So I have seen over the last many years some small successes, movement in the right direction. There are panels like this and opportunities and programs pushing forward social factors and recognizing that social factors influence health. There's buy-in that this matters. And that we need to do something about it. And we need to go beyond sort of health care to drive population health. There's been huge movements to foster multidisciplinary care and growing number of example programs trying to meet patients' health-related social needs. And there's Also, growing literature with robust evaluations showing that social care interventions improve health outcomes. Despite those successes, the reality is that there remains many, many challenges. So in my emergency department, I routinely see the patient that comes in DKA and diabetic ketoacidosis. And of course, I can give her medication and insulin. But as we know, unless that insulin is affordable, unless she has access to healthy food, a fridge, we're not going to actually help her overcome her underlying medical illness. In my emergency department, about 30% of patients that we see are experiencing homelessness. We cannot meet one of their main health needs around housing in our healthcare system. So right now, I would say our healthcare system is still not set up to meet patients' social needs. Take outpatient clinics where we require people to take time off work to figure out childcare, to figure out transportation, to come to the four walls of a clinic. Take my emergency department and all emergency departments really that are not really set up to coordinate with the social care safety net either. We need to make things easier for our patients. And we can't do that unless we have close partnerships with social service agencies like housing agencies and like experts in food security. Right now in healthcare, the focus is obviously on clinical service delivery, but what patients often need goes beyond clinical services. Their health and their wellness is really dependent on what we've heard on the previous presentation: housing, food, safety, wellness. So we need to change the culture a bit so that we're offering our patients and our communities a chance to say what they actually need, what is their self-identified needs, and then invest and respond to those needs specifically. We also need to invest more in our social care workforce. So social workers, community health navigators. Right now, again, in my emergency department, we might see 200 patients a day, and we're fortunate that we have a social worker in our emergency department, but the demand for their services far outstrips their capacity to meet those needs. There's an opportunity to invest in standardizing and expanding the services that can be delivered through multidisciplinary teams. And then finally, I think there's still confusion about the difference between meeting patients' individual health-related social needs and really meeting community social determinants of health. And this was really well articulated in the Health Affairs blog in the past couple of years. We need to move towards actually early childhood education efforts, poverty reduction efforts, ending structural racism if we're really going to drive population health on a fundamental level. So many of these points were well articulated in a new report by the National Academy of Sciences, Engineering, Medicine, led by Kirsten Bibbins-Domingo and many other great leaders in this field. And they articulated a couple key sentiments that are needed to drive this work forward. So it will require increased awareness, asking our patients, what their social risks and assets are. It will require clinical adjustment, so adjusting what we do in the clinical setting to respond to those needs. It will require giving them assistance, so ensuring that they have transportation and food vouchers to meet their basic needs. And then alignment between the healthcare system and the community, understanding what social care assets exist in a community and helping organize and facilitate sort of improving health outcomes based on what communities need. And then finally, advocacy to really drive policies forward. I think opportunities for CMS, I'm so grateful that CMS is investing and thinking about these issues. And I think there continue to be opportunities where CMS could clearly define what aspects of social care are covered, incentivizing sustainable financing for effective interventions, and then honestly also incentivizing healthcare organizations to really partner with community-based organizations that are doing this work around housing, around food, around safety. Thank you for your time, and thanks for giving me the opportunity to provide these comments.
Thank you, and thanks to all the presenters. It's such a wealth of knowledge and experience. We've gotten a lot of questions, and I'm going to try, there's no way I'm going to get through all of them, but I'm going to ask for some of them at least that we try to take a quick answer and maybe slow down on some of the more complex ones. None of them are easy. but don't all of you feel like you have to respond to all of them. Let me just begin with a comment/question that was raised. Not all electronic health records are the same, and it may be that particularly smaller practices under meaningful use adopted EHRs that are maybe not as functional, maybe not as easy to use. To what degree do we think the variability across these systems might be driving some of the differences we see in the measures? Anyone have thoughts on that topic?
Yeah, I'm happy to take a first stab. Then Dr. Smith, if you want to go first, feel free.
I tell you, one of the things that we didn't mention, which was the roadmap to interoperability. I mean, clearly we needed that in order to be able to get the data that's necessary. And then we're looking at HL7 FHIR. Where are we now with the ability of capturing those social determinants of health and actually quantifying them and having that information across all EHR systems? I could tell you, and having observed the function of the health information exchange systems in multiple states, they're not all the same, nor are all of our EHRs the same or the capability. But if we had some type of standardized interoperability and utilize a platform like the HL7 FHIR, allowing us to capture that data, then we can utilize that with our population health strategies. I'm not sure if we're ever going to get all of the EHRs on one platform that makes sense to all of the different practices, but we certainly can promote interoperability.
Yeah, and just to add to that, I'm really glad you brought up interoperability. There is some evidence that there is provider level variation and sort of EHR vendor level variation among providers in their performance on meaningful use and other sort of technology related quality measures. So we definitely do see that there's vendor effects here. I think there's a big conversation to be had around the certification process that's run through the Office of the National Coordinator, and how we raise that certification process up to a level where we know that every EHR, regardless of every EHR, is going to reach a baseline level of performance, especially with respect to interoperability and the ability to share records and information, both clinical and SDOH information, with other providers.
I'm going to keep moving through questions because I have so many of them. Someone asked, if you're in a small practice and you're trying to have a modest-sized set of measures for how you're doing on reducing disparities, where would you start? Do we have a small measurement set focused particularly on disparities? I'm not aware of it.
I'll answer that. I'm not aware of it either. No. And I think that would be a place to start. It was one of my earlier comments. We don't have good measures on this. And we are actually open to thinking about it and suggestions on how to do it.
Alan, I'll just add, I think the data that we collect is obviously very important, and there have been a number of studies that demonstrate that race data is a huge missing gap, and so there has to be, I think, a way to think about creating incentives around that, around payment models and some of the measure sets that are being developed, because without that data, we can't actually understand disparities at the local level, and at the end of the day, what you measure is an expression of what and who you value, and I think that has to become part of the data environment that becomes non-negotiable around this stuff if we really are serious about making headway.
I want to ask a question that I know is hard to answer, but Kenton, in your work, when you're looking at the differences, there is this last bullet that says it could be that we're actually capturing real differences in quality. And Dr. Smith, you very appropriately, I think, said that the measures reflect a lot of resource differences and history and continued systemic racism and resource differences across communities. How, in the end, do we try to separate this notion of what the underlying quality is from these measures that we know build in population and community characteristics that we have evidence penalize those who serve more complex populations and communities with fewer resources. It's like, what is the real objective is a tough word, but what is the overarching sense of what quality really is in this environment when our measurement is confounded by who we're measuring? It's a broad question, but I'd love to get some thoughts on it.
Yeah, it's a tricky question because both could be true. I know there's a report a couple of years ago from the National Academy of Medicine, I believe, that showed that people in poorer areas, have less access to care, particularly specialists, and may have less access to high quality physicians because physicians may choose to locate in more affluent areas. And so, it's entirely possible that what we're picking up is both a lack of risk adjustment for patients' full risk factors, such as poverty, and also we also may be picking up some lower quality of care as well. And so this is a big debate right now in quality measures of should we adjust for social risk factors or not. And there's a good argument to be made for adjusting for them because, the research clearly shows that social risk factors are associated with worse clinical outcomes, higher costs of care. But we also don't want to adjust away the effect of lower quality of care and just accept that as kind of the new normal for poorer patients or patients with other social risk factors. I know there's a lot of discussion, especially among the health economics community, about comparing within versus between provider differences. And so there being a way to adjust for these risk factors, in particular, focusing on the within provider differences. There has to be a balance that we have to be able to achieve here. The other counter to that would be, it's also possible for the same provider to treat patients of different SES strata differently. We hope that doesn't happen, but that's also a possibility that research has indicated as well. So this is really, I think, a tricky balance. Personally, I think we should adjust for social risk factors, but we need to do it in a way that doesn't accept lower quality of care for socially at-risk people as the new normal.
Just to add on to those great comments by Kenton, I agree that further looking into stratifying this within provider versus between provider differences is really important. I think in order to get better granularity about understanding the within provider differences and to understand the mechanism by which we see patients with high social risk have higher costs or lower quality, what we also concurrently need is just much better patient-level data regarding the social risk. I mean, dual is a very strong and powerful metric that I think has been shown repeatedly in the literature, but it's still concurrently somewhat crude. And there's a lot of different aspects of social risk that have been kind of elucidated during this conversation. And we need patient-level measures for different aspects of social risk in order to understand how those different aspects of social risk are driving the outcome differences. And I think there's been some recent literature that called out the fact that there are even ICD-10 codes that try to get at some of these different aspects that are incredibly underutilized and need to be expanded. I think Kenton might have been a part of that research.
I have two slightly narrower questions that I want to just get clarification on. You can hear me. Okay, so I'm so sorry. We lost power here in the storm, and anyway, I'll try to pick back up. Where I was is some narrower technical questions. There was a question about how the complex patient bonus is calculated, and there was a question about whether some of the interoperability scores of 0, instead of reflecting the absence of data, reflect the small practice exemption, and wonder if we could get quick answers to those, and I'll try to get myself back on board here for some of the bigger questions.
Sure, I can answer the question about the complex patient bonus. You can basically get added up to a maximum of 5 points, at least in the 2019 performance year. And this is based on the percentage of dual enrolled patients that the provider treats as a measure of social risk and their average CMS HCC risk score as a measure of medical risk. So it's a combination of your medical and your social risk. And if you treat patients, more patients that are duly enrolled and more patients that have higher than average CMS HCC risk scores, indicating they have more comorbidities, then your score is going to be higher. I'm not sure if in future years that score will be adjusted by CMS, but that's what I believe the plan is for the 2021 performance year.
Yeah, and as far as interoperability and the ACI scores are concerned, our analysis looked at the category level score for ACI. So that actually includes a number of different measures, one of which is your interoperability score. And the analysis that we did actually accounts for reweighting and those provider practices. Apologies. Those provider practices that were exempt from the that measure because they didn't have high enough volume.
Okay, I think I'm actually back on my computer. Please accept my apologies. Let's move to some slightly broader topics. A number of questions came in about what I would call distortions. You pay given the mismatch or potential mismatch between the MIPS score and what we know about scoring for social risk. Is there a chance that programs like these are leading to practices moving or concentrating in wealthy neighborhoods, to consolidation into larger groups, to feeling like solo practice is impossible and they need to go into an ACO, which Dr. Smith, I think you described it as a positive experience in your end, but maybe others would like to at least have that option. What's the overall sense of whether this set of initiatives around value are potentially having some distortions other than just rewarding high quality? It's a broad question. I'd encourage any of you who want to answer to jump in.
I don't mind jumping in really quickly. I know in some other research, myself and co-authors have looked at clinicians who are affiliated with large health systems performed much better in the merit-based incentive payment system, suggesting that clinicians with both the technological infrastructure, but also kind of the management and information infrastructure to enable them to identify and self-select the performance measures on which they perform best, do best in the program. Because, one of my biggest concerns is because the MIPS is a zero-sum program that involves actually taking resources from some clinicians and giving it to others. My concern is that there's a competitive advantage for clinicians with with the information and management infrastructure to best game the system, and that we could end up having a transfer of wealth away from poor areas to richer areas where health systems choose to invest. That would be a wholly unintended consequence of the MIPS, and I think it's something that researchers should definitely continue to study, because I know that no one wants that to happen.
Dr. Smith, I'd be really interested in it looks like you're raising your hand, so we're thinking the same way, please.
Yes, you are. I'm going to sum this up and say doctors with data make a difference. And if it takes us to be part of an APM that is able to get the data from CMS, and I'm going to say also our commercial payers, because we're taking care of other populations of lives. And if we're able to get that data in a useful manner and use it for coordination of care and use it for structural programs within the ACO model, And if the independent practice, such as myself, if we're able to have a higher level of function with less burden that makes sense, then yes, to join in a collaborative, it does make sense. I think for those of us to think that we can continue to dwell in the world of solo without collaboration and assistance, not only are we hurting ourselves, but we're also hurting our patients that we're taking care of. So to sum it up, doctors with data make a difference. And if you are without the data, you're not going to make very much of a difference.
So, and just as another comment, it is true that in those tax ID numbers, those TINs that are larger, as you saw in our data, those clinicians do better. And I think a lot of it is the systemness and the availability of resources, particularly advanced electronic medical record and analytic systems. There are within the MIPS program, within CMS, multiple levers that we have tried to help smaller practices and rural practices in particular, more QIO support that is dedicated to these practices, more outreach support in order to help those practices become successful. And actually, we have seen improvement in the scores of those smaller and more rural practices over time.
Dr. Kanzaria, you're, of course, in a very different environment, sort of the opposite of the small solo practice. What's your, so MIPS is probably not on your mind every day, but what is your sense about how we generate the resources that you think are needed, that in your experience are needed to measure and respond to what you see in your practice?
Yeah, absolutely. Thank you. So I'll say, we just went on a enterprise EHR last year, and prior to that, we're on 60 different electronic systems that when I took care of a patient, have to open up at least 5 different systems to take care of one patient in front of me in terms of radiology, clinical decision-making, writing my note, et cetera. And so it's a challenge to meet some of the requirements. I think at the hospital level, we met the meaningful use requirements, but when we ask, our patient population, and some of the measures are on, patient use of portals and things like that's very challenging, for us to meet. And I would even say we need to take it a step further in terms of interoperability. So now we have an enterprise EHR, but trying to leverage all of the tools in it. We're still at the very beginning stages of that, and there's no interoperability between our healthcare system and, again, our social care system. And so if we really want to understand, what are patient social needs, and then where are they accessing social care in the community, and how do we identify gaps and assist our patients, we're not there yet. We're really far away from that, but that is where we need to go. And again, I encourage, interested in everyone's thoughts on that, but I think that's where we need to go.
Yeah, Rocco, please go ahead.
No, I was just going to say, I keep going back to the conversations we have with folks in North Carolina and around the country, and just that disconnect I said that I felt at CMS. I think, I feel it acutely all the time, and so it's like we've created this box called MIPS, but it's in a bigger box called MACRA, and to be clear, that when we talk with folks in communities, no one said if someone would just come into my community and lower our 30-day readmissions rates or improve patient experience scores, we would actually achieve health. And so how do we begin to build those things into the system? I think a lot of what Michelle was beginning to get at, and at a minimum, knowing if your patient is food insecure or housing insecure would be at least minimally, as important as that other stuff, especially if we're going to have any hope of addressing racial disparities. And that's not even mentioning what's happening around COVID. And so, when we talked with physicians, we heard the same thing. And I think we can either stay in that MIPS frame, or we can really think about the opportunity right now to expand that and build off of it through the measures and the financial incentives that engineer everything that Dr. Kanzaria was saying, to really kind of move in the direction of health, which is what folks really want and hope that we'll be able to do as leaders of the healthcare system.
Well, as we count down the minutes, I'm just going to say this has been an incredible conversation. I'm an optimist by nature. What I hear is that our measures of social determinants, and that's a very broad term, but our measure of the barriers the people we serve face are limited and need work, but we're putting a lot of energy there. Our tools to address those barriers also need a lot of work. We're putting effort there. Our ability to translate all of this into payment systems that create incentives for health, but then don't penalize those who are trying to help those at the greatest disadvantage, also need work. But there's a lot of that effort going on. So I feel like there are many things that we're in a learning phase around, that this is the early stages of a journey. It's not that addressing social determinants is a new concept for people in healthcare, but there are large parts of the healthcare system that are taking this on afresh, and we're asking a lot of physicians and clinicians in general that many of them don't have a lot of experience working on. And what that means is that our tools are not quite there yet, but there's a whole lot of interest in it. And I see major investments occurring in all of those areas that hold promise for the future for the kinds of goals that all of you have spoken about. So I just want to say I'm really grateful to all of our presenters for the time you've given us today. I really liked the range of sort of hard research and description and experience. Thank you to the Physicians Foundation for making this event and our publications in the practice of medicine possible. And to those of you in the audience, please come back and look at the recording if you missed pieces, and the slides are there as well. To all of you, once again, thank you very much. And that brings us to the end of our program.